People who had sex at least once a week had a lower mortality rate during this course of the study. Now, that's not necessarily causative. It could be more of a correlation. But when you are sexually healthy, it means you're also physically healthy enough to have sex. You have a relationship with someone who can be your partner. You're also probably spiritually healthy enough. You are emotionally healthy enough. So it's kind of looking at all different parts of health. It's all wrapped up in sexual health. And we know that sex has all kinds of benefits. It can help your hormones. It helps, increases your oxytocin, which is really good for stress. It can help your sleep. It can boost your immune system, decrease your blood pressure. There's all these benefits to having sex as long as it's enjoyable and it's something that you're wanting. And I think that we need to look closer, especially for women, at the relationship between sexual health and longevity.
Hey friends, welcome back to another episode of Better with Dr. Stephanie. It's me, your host, Dr. Stephanie Estima. Today, I am bringing you a conversation all about hormone replacement therapy, skin, and sex. How are all those three related? Well, you are going to find out with my guest today, Dr. Amy Killen. She is a leading longevity and regenerative physician. She's a founder and a speaker. Her and her partner pioneered the full body system cell makeover. Dr. Killen is the founder and CEO of the Human Optimization Project, or HOP for short, which is a longevity-focused nutritional supplement company. She co-founded Humanaut Health, like astronaut, but for humans, Humanaut Health, a longevity clinic franchise, and the N of One, a health tech data aggregator, empowering insights through experimentation. So Amy and I have had this opportunity to connect on my show where we talked all about hormone replacement therapy. So we talked about progesterone, we talked about estrogen, we talked about testosterone for women, at what times, what ages. We want to be thinking about some of the different dosing and philosophies and considerations around HRT. We also talked about sexual health and the interplay or the connection with sexual health and cardiovascular health, muscle health, oxytocin, mental health, anxiety, stress mitigation, etc. And then, of course, we talked about skin. So we talked about stem cells and therapies for improving the appearance and youthfulness of skin. We talked about Botox, which is something that I have clearly been talking about with lots of people lately because I'm interested in it, looking at the safety profile and whatnot. So we talked about Botox, we talked about fillers, we talked about other ways that we might think about improving and preserving our skin health as we age. And then we finish with Amy sort of giving us her stack, if you will, of supplementation and interventions that she is currently doing to keep herself feeling her best at this point in her life. So I think that this is going to be a really educational conversation. You've heard a lot of the philosophy around training and nutrition from me in previous episodes. So we just go right into the hormones. Let's just talk all about hormones and talk everything about them. So please enjoy my conversation with Dr. Amy Killen. Dr. Amy Killen, I am so happy to welcome you to the Better podcast. Welcome.
Thank you so much.
You are just a wealth of information. I just want to dive right in. So let's actually start with hormones, because that is what the audience we're going to give the people what they want. We're going to talk about hormones.
Exactly.
Yeah. My audience, as I was saying to you, primarily in perimenopause and menopause. So I thought that we might start with some of the common perimenopausal changes that you see in practice. And then let's talk about some of the remedies that we might discuss beyond mastering some of the lifestyle basics. Like the lifestyle basics, they got it covered. I do that. They know all about weightlifting, and they know about protein, and they know all of that stuff. But let's actually get into the juice of the matter. Let's talk about hormone replacement therapy. So first, common changes you see in perimenopause, subtle and not subtle. And then let's move into HRT.
Yeah, so perimenopause can start, even up as 10 years or so before menopause. So you're seeing people, 35, 40-ish, sometimes even earlier, will have these symptoms. Oftentimes, it starts with difficulty sleeping. It starts with irregular periods or heavy periods, or all of a sudden you're having all kinds of PMS symptoms than you weren't before. It could be anything from headaches to anxiety to brain fog. We can see weight gain during that time. There is an increase in anxiety as well, just in general, like anxiety, depression happens as well during that time. And a lot of these symptoms are because your progesterone level is starting to go down. And the reason for that is you're not ovulating as regularly. And when you do ovulate, you have to have the follicles from the ovulation to create the progesterone, that second half of your cycle. And so you don't have that happening as regularly or as well. And so you don't have as much progesterone. And that's causing a lot of these symptoms. You have high estrogen relative to your progesterone in early perimenopause. And then towards the end of perimenopause, your estrogen has also been creeping down over time. And then you start having sort of menopause type symptoms like hot flashes and more weight gain and more brain fog and dry skin and all of those things.
Yeah. And I would say that certainly, having a regular cycle. So a lot of people will say, oh, I'm in perimenopause, my cycle is irregular, but you can start seeing some of these changes still with a regular cycle. One of my friends, Carrie Jones, who you probably know as well, I think she's maybe a year older than I think she's maybe 47. Sorry, Carrie, if I'm dating you, but I think she's 47. And she's like, I still have regular cycles. Cycles are still like 26, 27 days, to the month, every month. But she's noticing a lot of changes in her stress tolerance and her sleep. So some of these things are very subtle. I think even things like not wanting to socialize, becoming more introverted, becoming more withdrawn. If you're someone who, thrives in your community, or you have, a good group of friends, like getting ready seems like this arduous task that, prior to entering into perimenopause, it was like, oh my gosh, it's going to be a girls' night. It's going to be wonderful. So these things can seem a little bit more, they kind of creep in and you don't necessarily attribute them to peri.
Yeah.
I would also say things like sensitivity to noise. Carrie, again, bringing up Carrie, she talks about like ringing or like tingling in her ears, which can be a sign of estrogen, sort of like that, wildly, oscillating
fluctuating
levels of estrogen as well.
Yeah, that's so funny. I didn't even think, I'm 48 and I still have regular periods and I don't have, I do have problems sleeping, but I haven't even thought about the socializing aspect, but I totally find myself doing that. I'm just like, I just want to stay home and watch a movie. Why are we trying to have a party? Let's just stay home.
Date with the couch. Yeah, exactly. So and these are kind of the subtle things. And part of that, I think, is what you're outlining is that decline in progesterone. And then this, like, you're just not feeling yourself because you're up and then you're down with your estrogen. And that's also going to impact your brain, right? Estrogen, we know that estrogen has receptors everywhere in the body, including the brain. So what are the other thing I would love to talk about in terms of, so we've talked about estrogen and progesterone. Can we just outline a little bit of thyroid changes as well as maybe blood sugar regulation and insulin as well?
Yeah, great question. So I always tell people, people are always asking, what hormone should I get checked, in perimenopause? And you certainly can check your estrogen and progesterone. The problems with those are they're not necessarily, they're kind of going up and down depending on where you are in the cycle. It's kind of difficult to know, if you're in perimenopause just from checking those hormones. It's more based on symptoms. But we do see changes like thyroid, for instance. We'll see more hypothyroid, so more low thyroid symptoms in women starting in perimenopause, and that just kind of gets worse. We will also see an increase in insulin resistance. So higher blood sugars, higher insulin levels, kind of trending towards prediabetes and maybe even diabetes, again, starting in perimenopause. And so even if you don't check your hormones, which you still should probably, I do recommend that you check those other hormones. So you check your insulin, you check your hemoglobin A1C, your thyroid hormones, your cortisol, because these are all affected during that time as well.
I also notice, and this has been with, private clients that I've counseled and patients over the years, is that one of the big changes is lipids. So we will have, and we can talk about estrogen and the role of that, but part of that is also that insulin insensitivity that you've outlined, where now the blood sugar has kind of nowhere to go, like can't get into the cell to make ATP or can't get into the cell to make energy. And so of course the liver is now going to start pumping out more VLDLs, your triglycerides are going to start spilling, and then your liver is just gonna be like, well, I'll just pack it in here. Like I'll just start packing on, I guess, fat and that visceral fat. So it's also the phenotype of fat also seems to change in perimenopause, where we have this preferential fat deposition. It seems to be more visceral fat than subcutaneous. And everyone hates the subcutaneous. We're all like trying to get rid of the jiggle, but that in terms of longevity, in terms of impact on health outcomes, the visceral fat's the stuff that gets you. And that's sort of the laying the groundwork, if you will, for cardiovascular disease down the line. Would you agree with that?
Yeah, absolutely. And these are reasons why, some of the reasons why we start thinking about replacing hormones. Obviously we'll talk more about that, but we replace them for symptoms, but we also replace them for, prevention of long-term disease. And we know that, for instance, estradiol and testosterone, both in women, can decrease visceral fat. And then testosterone in men does the same thing. And it's hard to get to visceral fat. I mean, obviously, if you lose body fat in general, you'll lose some visceral fat, but you can't target visceral fat specifically, right? And that's the more inflammatory fat wrapped around your organs. And same thing with lipids. We know that estradiol specifically can reduce lipids, including LDL, and it can improve HDL, it can improve ApoB and Lp(a), which are these very specific markers that are going to increase your cardiovascular disease. And estradiol is one of the things that can actually reduce those things, where many medications cannot. So that's why we start looking at hormones, and why I think it's so important, especially when you actually hit menopause, that you are carefully considering HRT, not just for symptoms, but for prevention.
And what would be the age where someone might start considering HRT? So you mentioned before, and I think you said it maybe a couple of times now, that perimenopause is sort of like a moving target, right? So it's like you're always sort of different. In some ways, menopause is much easier to care for and address because you are a bit more of a static, like you can hit the target because you're not really changing that much. Whereas perimenopause does seem to be this wildly fluctuating time. And so what would be some of the clinical indicators? So we've talked about some of the sort of subtle and not so subtle signs of perimenopause. Is it based on our clinical experience, or are we looking at lab work to determine, hey, like my progesterone's a little bit low, even though my cycle's still regular, maybe I should start getting on progesterone in the second half of my cycle or all through the cycle? Like what is the consideration that a woman might have to start HRT?
So there's lots of opinions on this. My opinion is that if you're in perimenopause, so you're still having regular periods and you feel great, then and your other hormones are okay, your thyroid's okay, your other hormones are fine, your insulin, then you're probably okay not to take anything. If you feel great and you don't need it, you're sleeping great, then you're probably okay. However, when you get to the point where your periods are starting to really space out, and certainly if you've gone, more than 6 months or so without a period, menopause is technically 12 months without a period, but I believe you need to start HRT before that, because by the time you're 12 months out, you've had basically a whole year with little to no estrogen. Or progesterone. So certainly by the time you get to a place where periods are spacing out, then you want to get your hormones checked and get started on estradiol and progesterone and possibly testosterone.
And if we're looking at lab levels, so let's imagine, we can even use myself as a case study. So I'm 46. Actually, this Saturday, I'm going in for like my big, I kind of go twice a year to get all my blood work and all of that. What would be a cutoff level for, let's say, progesterone levels being low, would you say? Is there kind of a lab range that you're looking for, or is it just again, like you're pairing the lab with the patient's clinical presentation?
Yeah, you can look at labs. You can look at like progesterone on day 21 of your cycle, for instance, because that's when it's supposed to be the highest. And if you check it and it's like, 5, then that's basically means you don't have much progesterone. But that range is very broad. It could be, 100, it could be 5. And same thing with estradiol. Estradiol can be, 10 and still be normal because it goes from like 10 to 300 during your cycle. So it depends on when you're catching it. And we know that during perimenopause, estrogen is not following the rules necessarily. Like it can be bouncing around more than it should be normally, where you just get this one peak. But I would say if you have other symptoms or other signals, is that your FSH is creeping up. So that's your follicle stimulating hormone. Yeah. And that's the, sending the signal to your ovaries to make hormones. So if FSH is going up, it means that your ovaries are not doing their job properly. And your body's like, we need more hormones. And so it's sending more and more FSH.
It's like yelling.
Yeah, it's yelling. Exactly. It's yelling at your ovaries. And so when, FSH is 20 or 30 or 40, like as it creeps up, certainly if it's over 40 or so, then you're menopausal. But even if it's 20 or 30, you're probably getting there. You're getting pretty close.
Yeah. So is progesterone typically where you start? That's usually where I have seen, for women that are kind of in that late 40s-ish time, where they might be starting to see changes in their sleep, changes in it's usually I love what you said before around the anxiety, because it just creeps up out of nowhere. And unfortunately, so many women will go into their, let's say their primary care provider, and they'll get an antidepressant prescription, or in many cases you'll get a 52-year-old on the birth control pill, which is
I hate that so much. I just did a post on that today. I was like ranting.
Oh, did you? Oh my gosh.
I did.
It's so frustrating, and I just want to say that I have many colleagues, you included, who are friends who are medical doctors, and I understand that you are doing the absolute best that you can in the time and the constraints that you have in your medical practice. But I think that for women, Well, I think first that the training needs to change. I think that the training around perimenopause and menopause is sorely lacking. And I also feel like it's no longer a luxury for women to just kind of go on what the PCP is telling them. Like they have to also go in lovingly. Like we're not trying to go in and be like, like Dr. Stephanie, Dr. Amy, that's not gonna get you anywhere.
Right.
But you can certainly go in and say, hey, I've been, reviewing a couple of, whatever it is, pieces online. This is what I would like to do. Are you willing to work with me on that? And I think that that's where you are not tripping up someone's ego, and you're also demonstrating that this is a collaborative effort between you and your primary healthcare provider. So
yeah. Agreed. And you can also print out articles. I mean, doctors may not read them in the office, but if you print out really good articles and you bring them to your doctor and you're, again, kind about it and just say, I read this article. I think it's really interesting. Would you mind taking a look? I think some doctors won't, but I think a lot of them would look at it eventually.
Yeah. Yeah. In their off time, or certainly after hours, for sure. All right, let's talk about, let's keep on estrogen for a little bit, because I think that this is maybe the hardest one to get right in perimenopause because of the sort of wildly vacillating levels that we see. And I would like to maybe talk about some of the functions that estrogen has in the body. Certainly, we've talked about that on the show before, but I would love for your insight here. And I would love to maybe bring together some of your, you talk a lot about hormones, which is lovely. And I also want to bridge the gap between some of the other specialties that I know that you do a lot of work with, which is, sexual health and, of course, skin. I said to you when you first came on, I was like, you're the sex and the skin doc. So I would love to also talk about estrogen and some of the roles that it plays in sexual health, because I think that sexual health is, for the large majority of women, this is not a conversation that's being had with their primary, or even if they have a naturopath or a chiropractor or whoever, nobody's talking about their sex life.
Yeah.
I would hear in practice a lot after we had done, let's say, rehab on the pelvis and rehab on the sacral mechanics, and we've retrained, proper articulation. I would get patients then saying, you know what, I didn't want to tell you when I first came in, but I couldn't have sex with my partner because it was just hurting too much, or I couldn't be on top, or, whatever it was. And like now I can, right? So I would hear that a lot after the fact. Yeah. So let's talk a little bit about estrogen, sexual health.
Yeah, I mean, estrogen, as you said earlier, it's important for almost all of your tissues and organs in your body. There are receptors everywhere. So, from your brain to your heart, certainly your bones, your muscles, your pelvic floor, I mean, everything has estrogen receptors. And I think of it as like, when you lose estrogen, it's like this, it's sad to think about it, but it's like this slow degradation happens in all of these tissues. All of a sudden you go from sort of this anabolic state to this catabolic state where the tissues are starting to break down. And I say this as someone who's, fairly close to all this happening to me. So I understand that doesn't sound great, but in terms of sexual health, estrogen is very important for keeping the vagina and the vulva and all the pelvic floor organs healthy. So, obviously people know about as you go through menopause, you start having vaginal dryness, but it's more than that. You have, you'll have pain. The cells in the vagina become thin, it hurts. They're not healthy. You also have a lot of increased urinary incontinence, which is something that hardly anyone talks about. So you have to getting up to go to the bathroom more often, or you're coughing or sneezing and you're having a little bit of urinary leakage. And something as simple as just vaginal estrogen can make a huge difference in that, as well as reducing risk of bladder infection. So there's all these things in the pelvic floor. Some of them are sexual organs, some of them are bladder and other things that are influenced by estrogen. And when you lose it, then all of those areas suffer.
And what about, so the lack of estrogen in and around the vaginal wall? So what we're seeing there is we're seeing like rhabdomyolysis, like what are we seeing, like degradation of the muscle tissue? Is that why we're starting to see like the coughing and you get a little bit of leakage, that kind of thing?
It's like an atrophy of the muscles. And so you have less support of the bladder, because less support of the muscles and the urethra and the bladder itself. Well. And then you also have the vaginal tissue is changing as well. Like you lose some of the sugar proteins that are in there, or the sugar molecules that are retaining a lot of the hydration. So it becomes very dry. You lose some of the collagen. So it's changes that are happening, on the outside all the way up into the inside.
Is there any efficacy or any demonstrative evidence around red light therapy, like intravaginal red light therapy?
Yeah, there's a great device I give to my patients. It's called the VFit Plus by Joylux. I don't have an affiliation with them, but I've been using it for years on patients, and it's intravaginal red light therapy, just like you said. So it's basically all the same benefits that you would see from red light therapy. Increased ATP production from mitochondria, increased blood flow. We actually see improvements in mild, at least, stress urinary incontinence. So people who like coughing, sneezing, jumping causes leakage. We'll see improvements in that as well. It's fantastic. It's not a medical device. You can just buy it over the counter.
I love that because I have red light masks for my face. I have like one that I use literally every day when I'm checking emails in the morning, and I have one for like the neck and the chest. And there's a noticeable difference. Like there is a big difference from using it versus, not. And I feel like I've always had, somewhat good skin. I've always taken care of my skin. It's a little passion project of mine. I love skin health, but literally, it's like I unlocked a new level of skin glowiness.
Yeah. You do have fabulous skin.
Yeah. Oh, I appreciate that. But I feel like the red light therapy for the skin, I was able to, visibly see that. And so I think that would only make sense that we would also be able to see some of those improvements in vaginal health with a red light therapy device as well. So that's awesome.
We use red light a lot. I'm the same way. I have one that goes in my face. It's it wraps around my face, and I'll take these what I call face naps. I'll go in my room in the afternoons and just take a 20-minute nap with the thing on my face, and then I'll put the VFit in also. So I'm like double red lighted up.
Yeah, I love it. That's amazing. And so the other thing in perimenopause as well, and I'm 46, so you and I are kind of in the same boat. We're sort of trudging towards the same destination, is hair loss.
Yeah.
We see a lot of, again, under the influence of like that wild oscillations of estrogen. Are there ways that we can mitigate that? I mean, obviously trying to figure out like estrogen therapy. I guess and this is maybe what clinically I find challenging as well, is to give a perimenopausal woman estrogen, albeit the trend is, the overall trend is coming down, but sometimes she's really high, and then you have too much estrogen, and then she has the worst period of her life. Her breasts are tender. She's so how do we mitigate hair loss in perimenopause? Is it oral? Is it topical estrogen? Do we not give estrogen in perimenopause? Like what are some of the things
That's a great question. And there's a lot of debate about this. And I think you're completely right. I mean, I think that especially early and kind of middle perimenopause, and obviously you don't really know exactly where you are in this process, right? But in the beginning, estrogen is going up and down so much that if I give you estrogen, even though it's trending down, you're going to have these peaks. And just like you said, you're going to have like pelvic fullness and bleeding and breast full. You're going to think you're like miserable, and you're calling your doctor, like, what have you done to me? So that's why we kind of want to wait until your FSH is kind of starting to trend up, and we know you're a little bit more towards the end. But it's also based on symptoms. If you have someone who's coming in and they're having tons of hot flashes, and their skin is super dry, and they're having vaginal dryness, and they're not thinking well, and have classic low estrogen symptoms, and they seem pretty consistent, you can try a little bit of low dose estrogen and just kind of warn them that if you have symptoms of high estrogen, you may have to back off. But I tend to just wait, if I can, until those symptoms are starting, or till you're much closer to actual menopause before starting estrogen. Progesterone is fantastic. We'll start that, anytime. That you can start that in a premenopausal woman who just has heavy periods, or polycystic ovarian syndrome. Progesterone that has lots of uses, super safe, and doesn't have a lot of side effects for most people.
Do you like to cycle progesterone, or do you like to take it consistently?
In perimenopause, I usually cycle it in the second half of the cycle. So starting on day 14 and go into maybe 20, 28. Although there's some women just love it so much because it can really help with sleep, and it can help with anxiety and kind of just, making you calm. So some people will do a small dose every day, like 100 milligrams before bed, and then they'll increase the dose to those 2 weeks before their period. So maybe it's 200 milligrams in the last 2 weeks before their period. So everyone's different, but I do like to cycle.
Oral progesterone right now.
Oral progesterone before bed. Once you get into menopause, I don't usually cycle it. I feel like, get on a good dose, stay on it. There's no reason to cycle it.
Great. Let's move on to the most controversial of them all, which is testosterone. And I laugh when I say that because I actually don't understand why it's so controversial. Yeah. It's, if a man were to, I often joke and say, if a man were to go to their PCP and say, I just like my libido, I'm not, like before he's even finished the sentence, he has a script in his hand for TRT. It's like, oh, okay, I know exactly what to do for you. For women, I don't know well, maybe you can explain to me what are some of the patterns that you see? What is the misinformation that we have around testosterone and women?
Oh, yeah. I mean, the first is the idea that testosterone is a male hormone, which,
Sure.
we know that women actually have more testosterone in their bodies at any given time than estrogen. And so it is not a male hormone. We do have a tenth as much as men. So they certainly have more testosterone than we do, but we have a lot of testosterone as well. Testosterone is a little different than progesterone and estrogen in that it's going down slowly, starting at about age 25 in women and men. So it's this like slowly creeping down thing. It's made partially in your ovaries, partially in your adrenals. And so it's not like you fall off a cliff like you do with estrogen. It's just this kind of slow, downhill thing. And so maybe part of it is that we just don't have that like big revelation moment where like everything has gone to hell. Like it's so subtle, but symptoms are usually things like low libido, difficulty forming muscle, difficulty getting rid of fat, especially belly fat. Low motivation is a big one and that's oftentimes an early symptom. Like I just don't want to get off the couch. Like and also just kind of mood changes. Like I feel blah. And that's kind of it's maybe, it could be depression or anxiety, but it also could just be like, ugh, like I don't really feel anything.
And confidence.
Confidence is a big one as well. Yeah.
Yeah. Like I've had clients where they would just own the boardroom. You know what I mean? Like they were, I call them like boardroom Betties. Like they would just walk in, own it. Here's what we're going to do. This is the right thing. This is the wrong thing. And then they come to this point where they're like a scared little mouse and they don't know what they should do. They're second guessing everything. And it can be really, I think women in general, we tend to also say, what the hell's wrong with me? Like why, rather than saying, oh, maybe it's, my declining hormones as a function of my age or lifestyle or whatever, we tend to blame ourselves. So it can be, so many women won't even speak up about it. They don't even think that there's a problem that is correctable from an exogenous source, right? Like they think that it's an endogenous default, So let's talk a little bit about what would be, so typically low libido, I know is sort of generally accepted as a reason for giving TRT, testosterone replacement therapy for women. I know that there's a couple schools of thought in terms of how to dose testosterone for women. So some of it's like super physiological levels. Some of it's just treating, just trying to treat symptoms. Talk us through some of the different schools of thought, where you land and what you like to see maybe on labs, and then as well the clinical picture of the patient as well.
Yeah. So, I mean, one of the first problems with this is that there aren't any FDA-approved testosterone therapies available for women. So you have someone who's reluctant anyway to talk about this, and then she goes to her doctor and is like, I'm having low libido. She's like brave. She tells her doctor, and the doctor's like, oh, cool. Well, maybe you just shouldn't be having sex anymore. Or this is just, this is part of midlife.
I mean, why does she need sex anyway? She's
why do you need
46,
sex? It's fine.
You're
just getting old. And so the doctors, I've had doctors who have written me and said that prescribing testosterone for women is illegal. Like they actually believe it's illegal, even though, it's just an off-label medication. Any doctor can prescribe it if they want to, if they have a DEA license. So that's part of the problem. The dosing is usually about a tenth of the dosing we give to men. And there's different forms. You can do injections, which is usually a once or twice a week, just a subcutaneous injection is fine. It's just a little bitty needle. You can do creams. Gels. You can do troches, which dissolve under your tongue, and you can use pellets. So all of those are good options. There is, testosterone has been prescribed to women for over 50 years, and there are a number of studies, even though they're not talked about much. I think in the studies that didn't show benefit, the problem was probably dosing. They probably weren't dosing them enough. They're just giving them a little tiny baby dose. Dr. Rebecca Glazer has a lot of research on this. She's a breast surgeon, and she's done a lot of research on testosterone as an anti-breast cancer therapy, as well as a way to treat menopausal symptoms in women who can't take estrogen and other people as well. So she does a lot of research on this, and her finding is that you want to give physiological doses, so higher than physiological, in order to treat the symptoms, in order to actually see benefit. So, if you go by her school of thought, and she likes pellets, her school of thought is you put pellets in, and maybe the normal the reference range for the lab for a woman for the normal range is maybe 10 to 40 or 50. But she'll have patients on pellets where the testosterone level in the blood is 250. And they feel great.
Oh, wow. Yeah.
And they do have side effects, which is usually a little bit of increased facial hair growth, So she's like, get a laser for your practice and make sure you have that for your patients, because that does happen. But most people do fine.
What about hair loss? Would you do you tend to have that sort of androgenic?
Most people don't. And she's actually written articles about that. I mean, certainly there are some women who have noted hair loss. But when you look at the studies on it, there's not good evidence that testosterone really increases hair loss in women a lot. But I do think I have seen patients where that is a complaint sometimes. But
and
generally
any
it's not.
Changes in genitalia, voice, anything like that?
That can happen at high doses, so you definitely have to watch for that. You can get clitoromegaly, you can get deepening of the voice, again, at high doses, not usually a problem. And again, some doctors only recommend going up to the normal physiologic range. So you wouldn't want to go over, 50 or whatever that lab reference range is. And I think it really depends on the person. And my practice has been, let's listen to the patient and see how they're doing. If they're taking a dose that puts them on, 50 in the lab reference range, and they don't feel anything, they don't feel better, then maybe we go a little higher, but always keeping an eye on symptoms and making sure that we're not titrating too high for them.
And then is that super physiological? So does Dr. Glade, and maybe I need to have her on the show, but does she talk about this as a therapeutic intervention, sort of like a temporary super physiologic dosing, or this is just consistent?
Yeah.
It's consistent. Okay.
Yeah.
That's
and
so
she's talking about it a
interesting.
lot in terms of, like, she treats a lot of post-breast cancer patients who can't have estrogen, who are on estrogen blockers, like they're on, aromatase inhibitors and things that will prevent your body from making estrogen. And they're having really bad menopausal symptoms. And so she treats them with testosterone instead, because testosterone won't get turned into estrogen because they're on blockers. But the testosterone by itself will actually treat a lot of those menopausal symptoms and give you a lot of the same benefits as estrogen without causing increased breast cancer problems.
I think that's also an interesting topic too, because I've had a couple of doctors on talking about estrogen and breast cancer, because we see this link all the time. It's the number one reason why I think, part of the reason why I think women are scared to go on it. I had Suzanne Gilbert-Lenz, who is a breast cancer survivor. And she's like, you can take estrogen. You can take estrogen, even though you've had breast cancer in the past. She's like, I take estrogen. I have had breast cancer. Can you speak a little bit around, because this is there's these persistent myths, right? It's like estrogen causes breast cancer, testosterone causes prostate cancer in men.
Correct.
So we see these sort of pervasive myths, and it doesn't quite, I've always felt like it doesn't make sense because we have more estrogen earlier in our life.
Right.
So it would make sense teleologically, like from a sort of timeline perspective, for us to have higher rates of breast cancer earlier in life rather than later, because later in life we are in a low estrogen environment. So I don't know if you agree with me. Tell me what you're thinking.
No, I do. In fact, if you haven't read the book Estrogen Matters by Blooming, highly recommend. It's life-changing if in terms of the breast cancer story. Yeah, I absolutely do not. I do not believe that estrogen therapy or estrogen causes breast cancer. Now, certainly in some patients who have breast cancer, there's a period afterwards where potentially you don't want to give estrogen. Same thing with prostate cancer. Potentially, you're not going to give give testosterone to a prostate cancer survivor in that short period afterwards. And there's a lot of reasons for that. That's more of a saturation theory in men. But estrogen does not cause breast cancer. And there's a lot of evidence that HRT, estrogen, therapy doesn't cause breast cancer. And in fact, in a lot of studies, including the Women's Health Initiative, which was the big study, as you know, the estrogen only arm had a 29% decreased risk of breast cancer. It was the synthetic progestin that was paired with it that caused a slightly, but still not a actually statistically significant increase in breast cancer. But they called the study off because they thought it was trending that direction. And so it didn't even ever reach statistical significance. But it was the progestin piece that was the problem. So estrogen is not the problem. And we know that a bioidentical progesterone is protective against breast cancer. It does not cause breast cancer in the same way that a synthetic progesterone might increase your risk because it's so inflammatory. So I think that I don't know how to get rid of this narrative. It's been 20 years of women
I'm over
thinking
it.
I don't know how often we can yell about it, but so.
Well, I mean, my hope is that we will continue talking about it. We have a lot of doctors that listen to the show. We have certainly a lot. And when we inform and we educate our beautiful women who can then go to their doctors and say, hey, this is kind of what the latest literature, here's a paper, you want to read it in your off time. Like, I would love for you to, that's sort of how we slowly change that ship, because it was such a, I'll link in the show notes the solo episode I did on the Women's Health Initiative, but even just the manner in which they announced it, was so sensationalistic. There were women who like immediately stopped HRT, like immediately. Yeah. There was no wean period. They just stopped. Oh my God, it's going to give me a heart attack. It's going to give me cancer. I'm going to stop, which I think has had catastrophic.
Yeah, millions of women have developed, were off of it, and now they have osteoporosis. Now they have heart disease. Now they have dementia. Yeah. Now they're falling because they're weak. My mom, I've talked about her on Instagram before. She's in her 70s, and I put her on. She was taken off of estrogen during the Women's Health Initiative. I started learning about hormones 10 years ago in like 2013. And so I put my mom back on estrogen. She'd been off of it for 10 years. And I put her back on estrogen and
she was 60 at the time?
Yeah, she was early 60s, but she was also like, she was low risk for, heart disease. There's a kind of a whole thing you have to look at, right? But sure. I put her back on estrogen and progesterone. And I said, you're at high risk for osteoporosis because she's thin and Caucasian and, just all the kind of risk factors. And so she was taking it, but she still had osteoporosis just from previous years without it. And she fell and she broke her hip recently. And she's in the hospital and her doctors took her off her estrogen saying, you don't need this anymore. And then she goes home and she's off of it. And then now she's having like urinary frequency, trying to get, going to the bathroom 4 times a night because she has no estrogen. She can't sleep because she has no estrogen. She's on a walker. She can't walk. I mean, it was such a disaster. Like all of these things could have been stopped. It could have been avoided if she had just stayed on her estrogen. But she was one of the ones who were affected by that WHI.
Yeah, and that's so unfortunate. And is she back on now, or
she's back on it? Yeah, I got her back on it.
Well, I'm happy to hear that. That actually brings up another. I get this question a lot. I'm going to do a solo episode on this, but I would love your input here. If someone is post-menopausal, so obviously, like the ideal time, based on what I'm deriving from your opinion, is you get on some type of cocktail in perimenopause, whether it's like cyclical progesterone, and then you're on estrogen, let's say, and maybe some testosterone, even maybe testosterone prior, but the estrogen piece kind of comes into play, kicks in around menopause. What if you are one of the unfortunate women who have been affected by this narrative, and now you're 55, 60, you're well past that 12-month sort of window where you retroactively now qualify for this diagnosis? Can you start HRT when you're 60, 65, 70?
Yeah, you can, especially if you're doing a transdermal estrogen, which is going to be basically no increased risk of blood clots or heart attacks or any of those kinds of things. Although oral estrogen estradiol probably doesn't either. But the problem is that if you start it and you're more than 10 years from menopause, then we don't see the same cardiovascular benefits. So the studies that have been done and looked at, giving estrogen specifically to women, prior to 6 to 10 years out from menopause versus waiting 6 to 10 years to start those things, there's a big difference in the estrogen's ability to prevent plaque formation in the blood vessels.
Because there's already been significant buildup and infarcting probably in the arterial wall.
It's called the timing hypothesis or the healthy endothelium hypothesis. And basically the idea is you have to have a healthy blood vessel endothelium, which is the lining of the blood vessel. It has to be healthy for the estrogen to be able to prevent plaque formation. However, I still think that there are other benefits. Certainly that you can still have the bone benefits and the muscle benefits and the pelvic floor benefits to starting it later. There's still probably some lipid benefits. So I don't think that should be a deterrent for women. I think that if you can get it, start it later, do an estrogen cream and some progesterone, and I think you'll feel better and you'll do better. But you're not going to have as many benefits as if you start early.
And what about when do we stop, if at all?
I would say never, unless you're having a problem.
Yeah. So kind of as long as it's still supporting you, and it could be until the end of your life, really.
Yep.
Yeah. Wonderful. Okay. I think that was such a good, I'm so happy that we talked about this. You and I are aligned on so many facets of hormone replacement therapy. And I think that this has been so helpful. So let's talk a little bit about sexual health. So I think that all of this is going to tie in to what we're going to be talking about. But I think that there is so much taboo. I was telling you in the pre-chat, my book, one of the subtitle was, balanced hormones, intuitive eating, and then transformative sex. And it was like, what do you mean? And I think that it's always been men are the ones who derive the most pleasure from sex. And maybe when we're talking about sex, right now, what I'm talking about is like heterosexual, penetrative sex. I often think for women, and I can even just speak to my own upbringing, being Catholic, and it's like you only have sex when you're married, and it's just for procreate, it's just for having children. I talk a lot about this in the book in terms of like our anatomy and how the clitoris is just, there's no other function for it other than it being there to to give you pleasure. So maybe speak a little bit about why our sexuality, our sensuality, our enjoyment of sex, and maybe the different types of sex is crucial to our well-being.
Yeah, I think it's so important. This relationship between sexual health and longevity really gets glossed over. And I speak a lot at longevity conferences. These groups of people who are trying to slow down aging and extend lifespan and extend health span. And people are talking about all these different pieces, but no one's talking about sexual health as a piece of that puzzle. And there's, part of the reason is it's taboo. Part of the reason is we just don't have as many good studies looking at sexual health as we do other types of health particularly. But, there was a study in 2020, that was a big study that looked at people who were having, people who were having more sex, and the people who had sex at least once a week had a lower mortality rate during this course of the study. Now, that's not necessarily causative. It could be more of a correlation. But when you are sexually healthy, it means you're also physically healthy enough to have sex. You have a relationship with someone who can be your partner. You're also probably spiritually healthy enough. You don't have any, you don't have issues in that regard. You are emotionally healthy enough. So it's like, it's kind of looking at all different parts of health. It's all wrapped up in sexual health. And we know that sex has all kinds of benefits. It can help your hormones. It helps, increases your oxytocin, which is really good for stress. It can help your sleep. It can boost your immune system, decrease your blood pressure. There's all these benefits to having sex as long as it's enjoyable and it's something that you're wanting. And I think that we need to look closer, especially for women, at the relationship between sexual health and longevity. It's pretty clear what it is for men, but there's not as much evidence for women.
Wonderful. Okay, so that's awesome. Did the study look at whether or not the participants were was it a committed monogamous relationship? Was it just, and this is, and there's no judgment either way, right? It's
Sure.
like whatever works, whatever floats your boat. I have often talked about this idea that, for me and my husband, we've been together for many years, and I love the idea of building our trust and our intimacy over time rather than it degrading over time. Like there is this narrative that there's this like, oh, this is ball and chain and you're just going to be roommates and you're going to have sex a lot in the beginning and then it's just going to kind of fall off a cliff. And, certainly there is some mating, there is some, there's a different kind of love. There's a different kind of maybe infatuation, let's say, with someone when you first start dating them. But I would argue that our relationship, and this is just my own personal relationship, has gotten better with time. In particular, the sex has gotten better with time. As I've grown intimately with him, my trust levels, all of that. So can you talk a little bit about what the participants, were they in monogamous relationships, polyamorous? What did it look like?
They didn't say in the study, as far as I remember. They didn't. I imagine that they were, they're couples that they were studying, but I don't know that it talked about that. There was a study in the 80s that was interesting that looked at the 22 pieces of lifestyle and how they affected longevity. And what they found was that for men, the quantity of sex was associated with longevity. So men who were having more sex had a lot, longer lifespans, higher longevity. But for women, it was the quality of sex. Mm-hmm. And we do know that women who are in relationships tend to have better quality sex in terms of they tend to be more orgasmic. It's like the percentage of women who are having orgasms, with sort of early relationships or just casual dating, it's like 35 to 60%. It's really low numbers versus women who are in relationships tend to be closer to like 85%. So, that's only part of it, obviously, but I do think that there's some value for sure in that. The communication gets better, like you said, when you're with someone for a longer period of time. Certainly the newness goes away, but I think that there are other benefits that come along with it too.
I had someone on the show several years ago now, and when I first heard what she had to say, I was like, oh, wow, that's so interesting. I've never heard that before. And I don't know if I agree with what she said. She basically said that a cervical orgasm or a vaginal orgasm is essentially superior to a clitoral orgasm. And I was like, what? And so I remember thinking like, oh my God, am I not doing it right? Because I really, like the, like the clitoral orgasm is sort of like the best way for me. I was like, well, maybe it's just me. Like maybe that's just kind of what works for me. But I do think that this is a bit of I don't know if this is like a myth from like pornography, because whenever you look at porn, it's like, she's like 2 seconds and then she's like, oh, this is the best or whatever. I'm not saying that, but she's like, oh, whatever.
Freud actually was one of the early ones who said that basically vaginal orgasms were the best, and if you're having clitoral orgasms, like you're like, he called women who were having clitoral orgasms immature.
Yes,
like you're immature.
That's what she was. I was
and
like,
that the vaginal. But we also know that only 25% of women can have orgasms from penetrative sex alone without clitoral stimulation. So the rest of us, 75%, need clitoral stimulation. So I don't think anyone should feel immature or less than. I think if you're having orgasms, then you should be happy and certainly experiment with things, but there is no right way to do this.
Yeah, Freud was a tool on many levels. I'm just going to put it out there. Like misogynist, had absolutely no idea what he was talking about when it came to female sexuality. But I remember at the time sitting for this interview and I was like, oh my God, that's so crazy. But then I've had several sexperts maybe on the show since then talking about this idea that for most women will climax with some type of clitoral stimulation. And we don't even know. And the thing that's I think is even crazier is that, we used to think that there was about 7,000, 8,000 nerves. And I think now the number is up to like 10,000 nerves. And then it also extends into the bot. Like it sort of extends like where the, maybe the G-spot, might be. So I think that there's this ongoing discovery for female pleasure and how that, and what constitutes female pleasure, which I think is also very, very exciting as well.
It is interesting. I mean, even like what is the G-spot is still a question. Yeah. I mean, it's some people like, it's not really a spot, it's a zone. Some people are like, is it the back of the clitoris? Is it the back of the clitoris meeting the urethra, meeting the Skene's glands? Like there's all these structures that are kind of in that area. But first of all, not everyone has a sensitive area. Like not everyone has this G-spot magical, button that you can push and all of a sudden you're having 12 orgasms. Some people do, but it's, everyone's anatomy is different. And I think that the most important thing is that's the thing. Like everyone, the way that the nerves innervate the different structures is different for everyone. And that's, so, it completely makes sense that some people would find this pleasurable versus this pleasurable because we're all just hooked up differently.
Yeah. I mean, God, we all squat differently too. It's like, there's like some femurs are longer than others, like some active, we have different biomechanics. Of course, we're going to have we're going to have these differences, these nuances in our innervation patterns as well.
Yeah.
Let's talk a little bit about nitric oxide. So I would love, in the context of sexual health, but also I think that translates to other areas like cardiovascular health and skin health and all that. How are we, when we are, let's say, orgasming, or even just, maybe it's not even climax, maybe it's just foreplay and you are, breathing a little heavier with your partner. Talk a little bit about what happens sort of mechanistically or physiologically. And then I'd love to specifically talk about NO.
Yeah. So, there's the desire part and there's the arousal part. The arousal part is when your brain, starts getting excited. So it's got dopamine hitting it. It's got testosterone hitting it. It's got melanotropinon hitting it. It's got all these different hormones that are saying, hey, we're excited. Let's get excited. And it's sending signals then to your body to get aroused, right? So that's where you start having increased blood flow. And one of the signals that is sent to your blood vessels is nitric oxide. So you're increasing nitric oxide production, which is this, this chemical messenger that tells your blood vessels to vasodilate, to get bigger so it can deliver more blood to your genitalia. And nitric oxide is important for delivering blood all over your body and for keeping a lot of your cells healthy in general, but it's very important for sexual health for men and women. It's what causes erections for both men and women, clitoral erections for women and regular erections for men. And then that increased blood flow is also responsible for vaginal lubrication and women as well. So the nitric oxide is a key piece. And the problem is that as we get older, we make less and less nitric oxide. So by the time you're 40, you're making about half as much as your 20-year-old friends. And so this, the getting the blood flow is a problem. And in men, it's been well studied. We know we can look at erections and we can use different devices and kind of measure them and things. It's more difficult in women. We don't actually know as much about the role in blood flow in terms of like sexual dysfunction in women like we do in men. In men, we know that lack of blood flow is the number one cause of erectile dysfunction. In women, we suspect it's a cause, but we just don't know it because it's so much more difficult to measure those things in women.
And is there any relationship with NO and estrogen?
Yeah, actually, estrogen increases nitric oxide activity. And so it's going to increase blood flow into, various organs, including the pelvis. And it is going to, and nitric oxide also nourishes the cells in the endothelium, in the blood vessels themselves. So, so it does multiple different things. It's going to help your lipids. It's going to, there's all different things that it does. And estrogen is a modulator of nitric oxide.
And so are there ways, so we've been talking about HRT, let's say for dwindling testosterones or progesterone or estrogens. Is there supplements, replacement? How can us 40-year-olds keep up with, with our 20-year-olds with our NO levels?
I mean, there's certainly lifestyle things that you can do. Exercise is going to increase it. Getting a little bit of sun, red light therapy does it as well. Breathing through your nose versus your mouth will increase nitric oxide. So there's, some little tips like that. You can take nitric oxide boosting supplements. I like Dr. Nathan Bryan, who's a researcher, has a line called NO2U, which again, no affiliation, but they have some great little lozenges that have some good clinical evidence behind them. So you can take that. And then you can also take, even though it's off label, you can also take the PDE5I inhibitors like Viagra or Cialis. And what they do is they essentially prevent the breakdown of nitric oxide. So it keeps your nitric oxide around longer. So even though those are not FDA approved for women, if blood flow is an issue, then those drugs can be helpful.
Oh, that's really interesting. So off-label for women.
Yeah.
And can we measure NO? So I know that you mentioned with men, it's very well established. Is there a way that we can measure it? And is there, let's say, a reference range that we might be aiming to?
So you can measure it. I mean, you can sort of measure it. There are some salivary test strips that you can get from Berkeley Heart or, some companies just on Amazon that you can just put some saliva on a strip and it'll turn different colors of colors of pink, and it can tell you if you're low or high or medium. The problem is the actual gas that is in your body only lasts a couple of seconds. And so it's very hard to capture it. But I think the test strips are a good approximation, but then also just symptoms. If your blood pressure is going up, if you're having erectile dysfunction, if you're having some of the, if you're aging, if you're diabetic, if you have high lipids, these are all symptoms that are associated with low nitric oxide as well.
And tell us about the effects maybe that alcohol has on, I would say, on our overall health, but in the context of this discussion, sexual performance and sexual function as well.
Yeah, alcohol is interesting because if you take a little bit of alcohol, some people will find that it's helpful for sex. It lowers inhibitions and it can be helpful, and you feel a little bit more, it can spice things up a little bit. But certainly after a couple of drinks, and depending on the person, it becomes a depressant. And so it's not only decreasing your mood and changing your ability to stay awake and things like that, but it's also changing the way that you're going to be getting blood flow to your sexual organs. And so you definitely want to, maybe a glass of wine, but certainly not multiple glasses of wine if you're interested in having sex.
I am never, I mean, I gotta state my bias. I don't think that there's any place for alcohol ever.
I mean, I don't think it's healthy. I'm not saying it's healthy. I'm just saying that I think that some people find it helpful.
Yes.
Even if it's not healthy.
It just sort of takes the edge off, right?
Yes. Yeah.
I think that that's one of the, and maybe this is just where I bristle up again and maybe I just need to chill the hell out. But I just find that so it's my perimenopausal women. They're always like, me and my husband, we just like a glass of wine at the end of the day. It's been a hard day. Kids were teenagers getting in all sorts of trouble or whatever it is. And it's, alcohol is typically consumed in the evening. Most of the time it's consumed in the evening. It's liquid calories. It's very quickly changed into, it's just liquid sugar essentially. And so it just necessarily and predictively tanks your sleep every single time. And I don't really drink. Maybe I'll have a glass. I had a glass of champagne at my wedding, and I had, because everyone was raising a toast. I'm like, well, I guess I'm not just going to have the water. I'll have the actual champagne. And maybe I have one glass at Christmas or something. But my HRV tanks the next day. I sort of wake up. I feel like I have had a sock in my mouth the whole night. I'm such a lightweight. I just need a glass and I feel that way. So that's because my tolerance is very, very low to it. But I struggle, I remember back in, gosh, I can't remember when it was with the resveratrol, when they were like, oh, the resveratrol and the red wine and the French paradox and this is what, and I I still struggle at that point to justify any alcohol, because the amount of alcohol you would need to take to have that heart like the resveratrol protective effects that it has on cardiac tissue and whatnot. You would have to have like barrels of wine, which of course is going to negate,
and the resveratrol, the whole resveratrol thing has really been, a lot of it's been disproven anyway, even just the resveratrol piece of it and the sirtuin story and all of that. So I agree with you. I mean, I do enjoy wine occasionally, but it always messes with my sleep. And I do think that in women, especially once you hit 40 or so, that becomes more of a problem. I think that, even just a little bit of alcohol tends to mess up sleep more. Whereas, if you're in your 20s, you can have several glasses, you can sleep just fine. It gets worse as you get older for sure.
Yeah. Let's talk a little bit about, I know we've been sort of integrating it into our entire conversation, but let's talk a little bit about skin. One of the things you do and one of the things you practice a lot, and it's not just for skin and for anti-aging or, cosmetic, but there's a lot of stem cell, peptides, exosomes, things of that nature that are in your practice. And I actually forgot to mention this in our sort of sexual health conversation, but there's like the O shot and things like that. Mm-hmm. Talk a little bit about the role of peptides, and we can talk about bioregulators, we can talk about longer chain peptides in the role of anti-aging.
Yeah, I think that, there are several great peptides for skin. Certainly GHK copper, for instance, is one that you can apply topically. It's in a lot of the lotions and potions that are out there now. You can get cosmetic products with it in there. We used to be able to use it as an injectable as well. It has a lot of other benefits besides skin. Certainly in the last few months, the FDA has cracked down on us being able to prescribe peptides, except for there's a couple of oral ones and a couple of topical ones we can still use, but we can't use injectables. But, there are other peptides like L-arginine is another one for skin that's a topical that's great. BPC 157, which is tends to be thought of for healing musculoskeletal pain, and for gut health is also really good for skin. So there are a lot of peptides. And then I do a lot of skin stem cell procedures for skin as well as for hair restoration, injecting stem cells and or exosomes into the skin, and then microneedling as well and applying them topically. So I use a lot of those type of biologics as well.
So talk a little bit about what's the mechanism for the stem cell? What type of stem cell are you ingesting or injecting, I should say? There's different categories. There's like mesenchymal or stromal, I guess, and then there's maybe embryonic. I don't know if those are even used anymore.
Yeah, we don't use embryonic.
Yeah.
So we use mesenchymal stem cells. So these are also called MSCs. Some people consider them more like signaling molecules than actual stem cells, but essentially these are cells that are in all tissues in your body. And we can either take the stem cells from the patient, like we can get a little bit of bone marrow or a little bit of fat and get your own stem cells and then put them either in your skin or your scalp or your sexual organs or your joints or wherever. Or we can also use stem cells that are in like placental or umbilical products that are donated. So these are like full-term babies. And then instead of throwing away the placenta and the cord, they donate those tissues to a lab and they get processed and they get screened and all of that. And you can use some of those tissues they'll have like the exosomes, which are like extracellular vesicles, like the signaling molecules. And they'll have like Wharton's jelly, which is like hyaluronic acid, which is good for skin also, as well as stem cells. So there's various pieces, but the way all of it works is pretty simple, which is that when you, like for instance, for skin, if you're injecting these things, the stem cells or exosomes, they send out signals to the cells that you already have in that area, like your own skin cells. And it tells your cells to become more active. So you get increased blood flow, you get increased collagen and elastin and hyaluronic acid formation. So it kind of takes these cells that are in your body that are kind of in a more resting state, and it tells them to become more youthful cells. So that's how all of these regenerative therapies work.
And how often, how many stem cells are required in order to affect change? What is the frequency with which you need to be engaging in this? And
all good questions and things that we don't really know. I mean, there haven't even been head-to-head studies with like if I use your stem cells versus umbilical cord stem cells for skin rejuvenation, which one's better? Like we have studies that show your cells are helpful. We have other studies that show stem cells from Placentas are helpful, but there haven't been any head-to-head studies, and there aren't a lot of big studies for sure. These are mostly kind of small studies. They seem to all do the same kinds of things in terms of the ways the signals they send out, but we don't know the dose necessarily. We just kind of are estimating. Most people will do them no more than once a year, depending on, maybe exosomes more frequently because they're less expensive and a little easier to do. But, stem cells, they're pretty expensive still. And so most people are not going to do them more than once a year. Sometimes it's, every few years.
And what is is there a general range in terms of pricing? Like when we say very expensive?
Yeah, it really depends on how much product you're using and how good the product is and how, and where you're getting it from. It could be, for exosomes, I've seen as low as like maybe $1,000 for a treatment, but that can go up to, $5,000 or $6,000 or even more, because the cells themselves and the exosomes themselves are pretty expensive. So the procedure is easy. It's not a big deal, but the tissue products are pricey still. I think they'll get better, but yeah, they're still expensive. The good ones are still expensive. You can get ones that are not very good for less, but the good ones are still expensive.
Yeah. And it's really the sourcing of the product that's more important.
Yeah.
Yeah. What are your thoughts on Botox? I had Tony on the show. Oh, yeah. I guess it was a couple months ago now. A good friend of mine, known him for years, Tony Yoon. He said something that I thought was really interesting, which was Botox is the most used, how did he say it? It's the most used product or beauty product, I guess, in the history of the world. Wow. Yeah, like ever, like from the beginning of time.
Does that include what is a beauty product? Like lipstick? Is that a beauty product? I feel like
that's a great question. But I guess an intervention, maybe an injectable.
Okay. Yeah.
And he was very bullish on the safety profile. Like there's very low risk. Maybe you have, if the injector or if it's put in the wrong area, you can get like, if, you're doing it in the forehead, maybe you can have like droopy eyes, that kind of thing.
Yeah.
But then that resolves itself eventually because it doesn't stay. What are your thoughts on Botox as an anti-aging tool? And then I have a comment that I recently heard from another practitioner that I'll share with you. I'll share it with you now. His concern was when we are over Botoxing. So if you are Botoxing for years and years and years and years, what it's doing is essentially paralyzing the muscle so that the muscle's not being used. So of course, over, the trajectory of that, when you sort of pull it out over decades, is that now you're going to have atrophy of the muscle. Like if you're never able to use your forehead muscle, then that forehead muscle eventually is going to atrophy. So then you're sort of stuck in this, I have to do it forever, or, that loss of volume that can occur with time will necessitate other interventions. Maybe it's, I don't know if you do filler in the forehead, but other things. So with all that context, I'm just hearing a couple different things because in the spirit of transparency, I'm 46. I'm like, all right, maybe I need to kind of start working on this. Like maybe I need to start prophylactically working on this. So I'm also asking selfishly for myself as well, for all of you experts who are doing it all the time. So yeah. What is your thinking around, and I know this is like my Betty's, my audience also is like, we're all vain. We all want to look our best. So tell us, is Botox something that we should consider? Is there a real concern around atrophy of the muscle over the long term?
I think I'm probably in Tony's camp. I think that there are a lot of uses for Botox and other toxins, other neurotoxins. There's the ZMN and Dysport and all those other brands. They've been used now for 20 years or something, and we really haven't seen, obviously that's only 20 years. Maybe there's something at 40 years that happens, but we haven't seen a lot of side effects. And I think that it can be really helpful. I don't think that everyone needs it. I don't think, if you don't want it, that's great. I think you could be beautiful either way. But I do think that it's very, very safe. Botox has it's only ever been a problem, like a serious problem in super, super high doses when they're treating muscle spasms and people who have like paralysis and things like that. Like when you're doing normal facial treatments, no one has ever gotten seriously injured from Botox. Yes, you can have a droopy eye for, weeks to months, but it's maybe 2% of the time that happens. It's not very common and it always goes away. So from a safety profile, I think it's great. You could argue on whether it looks good or not. I think it depends on your injector. Some injectors are better than others for sure. Yeah. To the atrophy thing, that's an interesting point. I haven't seen it. I'm not saying it's not possible, but the places that we're injecting, another school of thought is it'd be great for those muscles to atrophy because then they wouldn't be it wouldn't be
Pulling on the
contracting
skin.
and causing your skin to wrinkle. Like
Right.
I would be happy if my forehead muscles were not as strong, because then they wouldn't be wrinkling as much. And the muscles that we're injecting are like, mostly it's forehead, like around the eyes, for instance. Those muscles they're not like these big thick muscles like they are in your cheeks and places like that. So I don't
Like you're
know.
still going to be able to chew. Like we're not paralyzing the masseter or anything like that.
You don't inject, I mean, in general, you don't inject much, but from like here down, like the cheeks down, you can do little bits here and there, but you don't want to hit the big muscles, because that'll make your facial expression, you'll have crazy smiles and all kinds of problems. So you really are just injecting the very like thin muscles of the forehead and around the eyes. So I don't know if atrophy, even if it happened, I'm not sure we'd notice it, but it's a good question.
Yeah. Something that'll certainly play out. And then maybe and then if there is atrophy, maybe you can compensate with things like filler, or maybe there's, at that point, maybe the stem cells, like you can inject stem cells to help with, my understanding of stem cells anyway, is that we're going to be driving up collagen and elastin production anyway, which is something that, we start to lose volume in the face. Like typically it's the lower half of the face, right? We start to lose volume, like kind of in the, we sort of get like maybe the jowls forming a little bit, and there's a little bit of this hollow, sallow, maybe lower half of the face with time. But hopefully with, studies and enough clinicians like yourself who are dealing with stem cells and peptides and bioregulators and all the things, with time we can figure out maybe it's a stem cell solution. Like maybe it's something that we can rectify with stem cell injections.
Yeah, I think there's a place. I mean, right now I have a lot of patients, some patients don't want to do anything unnatural. They don't want to do Botox. They don't want to do fillers. They just want to do stem cells or fat grafts. Then I have some patients that want to do all the things. And I think that I do think they all complement each other. You can do a laser, you can do fillers, Botox, and stem cells, and they all do different things that are all going to be additive to each other. So I think that that's completely fine. But I also understand that people who, don't want to do those things. And I respect that decision as well.
Yeah, I was saying to Tony when he was on the show that there's a couple of people sort of in, our colleagues that are like, it rewires the neural patterning in the brain. Like if you're taking Botox, for example, it's going to totally rewire. You're going to actually get more wrinkles because because there's certain muscles that are paralyzed, you're going to get these sort of like dendritic, you're going to get these little branches of nerves that are coming out to try and move the muscle. So over time, you're actually going to create more nervous input that you still need to overcome. And so there's I think I'm pretty neutral on it. Like, I'm like, well, if it makes you feel good, like, you do you, boo. Like if you feel good doing it, you should have access to it. And if you don't want to do it, then that's also your choice. I think like any medical intervention, it's a personal decision and you can just make your own choice. You don't have to declare it to the world. Yeah. But it's interesting how people can get very hot about it.
They can. And I think that, again, we'll know more. It's been a number of years, but we'll know more as time goes on. I think that sometimes people get hung up on like little mechanistic data. Like you can look at something in a petri dish and say that, Botox does this to a cell or a nerve or something. And then you extrapolate that and say, well, if this happens like this, then we put it in people, then the person's going to have this. But we haven't, there definitely are not any studies in actual people, clinical studies that have shown these problems. Not that it's not possible, but it's one thing to see these, some kind of effect, positive or negative, in a petri dish or in even an animal model. It's a whole other thing to see it in a population of people.
Yeah. What is your thoughts on, I don't want to call it face yoga, but there's someone that I follow online. I love what she teaches you how to sort of massage so for the eyebrows, let's say it's like you're massaging the eyebrow on the sort of the front and on the side, and like how to sort of get rid of nasolabial folds, etc. What is your, I guess face massage would be an appropriate.
Yeah. I don't know that I have a lot of thoughts. I think that there's probably some benefits to like at least some of the drainage pieces of it, the lymphatic drainage and getting the extra fluid out of the face. There's definitely no downsides to it, and it probably feels pretty good. So I think I don't know enough about the benefits, but I think it sounds like a relaxing way to spend a few minutes.
Okay. All right. So let's just as we're sort of wrapping this up, maybe I would love for if you feel comfortable sharing, what are some of the procedures that you love in terms of helping with your own skin health, maybe sexual health, and then just overall what we've been talking about in terms of hormone replacement therapy, and then supplements that are in addition to that.
Yeah. So I have my own supplement company. It's called Hop Box, HOP Box. And it's a longevity blend, which has it has 19 different ingredients in it, and including a whole bunch that are great for skin. So like astaxanthin and dihydroberberine and nicotinamide and riboside and spermidine, and some of these really good, powerful skin boosters are in there, oral hyaluronic acid. And they also has a bunch of things that are just good for increasing cellular health in general and kind of combating those 12 hallmarks of aging, the things that drive aging. So I have that company I use those every day. It's 2 packs a day. And then I also like to do, I have a lot of lotions and potions. I like a retinoid or tretinoin or something, every night before bed, I think is good for skincare for anyone over the age of 40. Good skincare in general is important. Sunblock is important, at least on your face and neck, like whether or not you want to put it everywhere. It's your choice.
Don't forget the back of your hands.
Back of your hands. I always forget my hands. I think they're showing. But I think sunblock is super important. And, I do think a little sun is great, but you don't want it on your face if you can avoid it.
Like dose and timing is important. Like I like to get sun in the morning. The sun is still low in the sky. I'm not getting a sunburn when I sit outside and I have my little coffee or whatever. But I put sunscreen on. And again, like I was saying this to Tony, like there's some people that are vehemently against sunscreen.
It's so divisive.
And who would have thought, like I never would have thought that would be like, I did a post a couple of weeks ago now on oats and how they're like a really great pre-workout.
Yes.
Really great pre-workout. Oh, people came out of the woodwork. They're like, oh my, and I said, never in my 16 years of private practice, along with like the 4 years of, online, that I ever think that this was going to be the definitive. People were like, I can't believe that you're talking about oats. They're sprayed with glyphosate. I'm like, listen, they are a great pre-workout. And you put some protein, a little protein powder. That's like a fabulous pre.
Yep.
So we are at the hot box twice daily. You said a retinoid or retinol. I'm assuming tretinoin, sunblock. Some other vitamin C in the morning, maybe, or copper.
Yeah, like a good antioxidant serum is great. Yeah. And I do use some peptide products as well. I like Young Goose has some great products with a lot of these like sort of biohacker ingredients, NAD precursors and a good vitamin C and things like that. So I like a lot of their products. Any kind of good antioxidant serum. It's you don't have to use
copper. Do you put copper topically?
Yeah, one of the products that I'm using, it's a new product from Young Goose that had they're friends of mine, but I don't have affiliation otherwise. But they have a spermidine, NAD, copper, and vitamin C combination product that I've been using that I really like a lot in the morning, and then I use a retinoid like a tretinoin, which is a prescription product at night usually.
Great. And then any other supplements to help with NO or any of the things that we've talked about today?
Yeah, I like Nathan Bryan's company for NO. So that's NO2U, like to the number. And then I also I take a daily creatine also, like 5 grams a day creatine.
Yes.
I think that's really important for women, not just for muscles, but for brain and all the other things.
Yeah.
And then the only other thing I take most days is I'll take collagen also, like a Verisol collagen, which is, skin and joints and things like that. And I don't always take that, but I like the idea of taking it.
I love collagen. I don't count it towards my protein intake for the day. So that's my little thing. People are like, do you count collagen? I'm like, no, because it is absolute. When we're talking about, muscle protein synthesis, it does not do any of that. But what I will do, this is my little BJ Fogg stacking habits. On my way to the gym, like I'll put myself a water bottle and then I'll pop in a scoop of collagen. So it's like the collagen I use is, Quip Foods, and it's vanilla flavored. It's lovely. So it's like a little bit of vanilla water when I'm working out. But that's the way that I remember it. Otherwise, I totally forget to take it. And then it's been weeks and I'm like, my skin, I feel like it probably should get back on the collagen because, skin health is, it's an internal, it's like how hydrated you are, but it's also, we talked a little bit about this, but collagen declines as we age as well.
Yes. Starting at 25. This one doesn't take very long.
That's crazy. Yeah. Okay, good. Okay. So collagen. All right. So this has been wonderful. I think that you've given us a really comprehensive overview of hormone replacement therapy, sort of where we are in terms of clinical practice and bridging that with some of the literature. And over the next coming months, we have lots of practitioners like yourself who are very much in this perimenopause and menopausal space, because I think that this is such an important conversation to continue to be having so that we can sort of, as you said, like, I know it's 20 years old, but we have to keep banging the drum so that our beautiful women can get the care that they deserve. So so people want to find out about you. I know you're still in private practice. So tell us a little bit about where people can find you. We'll certainly link your Instagram, but if people want to see you privately, virtually, any other ways that you would like to interact with our audience, please tell us now.
Yeah, so I am very active on Instagram. It's Dr. Amy B. Killen. I'm only taking new patients for stem cell therapy currently. I'm working on some new clinics that we're opening and things. So we will have some new clinics this summer, but until then, I'm not taking any patients except for stem cells. But then I also have Box, which is my supplement, which is hopbox.life. And that's fun. And then I have a website, which is dramykillen.com, which kind of links to different clinics that I belong to. And if you want to find me that way, that's a good source as well.
Wonderful. All right. All that will be in the show notes. Amy, it's just been a pleasure. I'm so happy that we had this time together today.
This is so fun. Thank you so much.